So, Kathy, why don't you fill us in on your area of work?
So I actually have several areas of work because in Indiana University, my main job is to function like a bridge. I spend most of my time in the clinic taking care of patients and designing and coordinating clinical trials. But I have always thought that if all you learned from a study that involved human beings is that this drug works in 20% of women, that's a bit of a dead end. I need to know who are those 20%, why didn't it work in the other 80%, and how could we use that knowledge from the clinic to go back to the laboratory to make the therapy better and to use that therapy more intelligently. So I spend most of my time in the clinic, but with an arm and a foot reaching across the bridge into the laboratory, with taking those laboratory ideas from the laboratory into the clinic, often in trials that test them in human beings for the very first time, and making sure that those trials include collection of blood samples and tumor samples and information that will go back to the laboratory for special studies. So we started this process looking at the growth of blood vessels more than a decade ago, with the simple recognition by many folks who have enjoyed BCRF support that in order for an area of cancer to grow, it has to get a bigger blood supply. It needs to bring in more nutrients, more oxygen. It has to get rid of the waste products. Very similar to if a city wants to grow into the surrounding countryside, it has to build roads and highways and put in sewer systems before you start building houses and moving people in. And if you could interrupt that process, you could make it harder for the tumor to grow. Now, the growth of blood vessels is a very tightly controlled process. You had to grow blood vessels when you went from a little embryo to a full-sized human being. When you have a major injury or a surgery, you have to develop the growth of blood vessels. And none of our healthy cells last forever. They all go through a normal turnover. So cancer cells have not created something new. They've just taken that normal control of blood vessels and shifted the balance to making more of them. Well, they make a lot of them. They don't function very well. So there are a lot of ways to try to shift that balance back. So we've worked with several drugs, some of which are commercially available on the market now, others still in early clinical testing, that attack the cancer in that way. They've had generally fewer side effects than chemotherapy, though some of their side effects can still be serious and life-threatening. And where we have struggled is really figuring out who to best use them in, which patients and which tumors would benefit. The advances in technology of allowing us to look much more detail in the molecular fingerprint of the tumor and also of the patient. When one of my junior colleagues who will be much smarter and much more famous than I pointed out that while the tumor stimulates the growth of blood vessels, it's actually the host, the woman or the man with cancer, whose body has to make those blood vessels, and maybe we should pay attention to who that patient is. And we found a lot more information looking at that side as well. We've taken this to other areas that we'll talk about it another time, so I can give my other panelists a time, but I hope that gives you a flavor of how we try to move things back and forth across that bridge to move the whole process further and faster.
Great, thanks. So, as we move on, and to provoke some, I hope, good questions a little later, I want to remind everybody that although Kathy didn't say it, what she's talking about indirectly and directly is the brand name drug Avastin, the bevacizumab that was so in the news about a year ago, a drug with real activity but some challenges. So this will be a good opportunity for people to think about their questions related to that.